Today I'm going to talk about the rotator cuff and the arthroscopic repair of the rotator cuff so that our patients can avoid getting reverse total shoulder replacements, at least in some conceivable situations. And the rotator cuff, what does it do? What is it? Does it help you throw a ball a whole lot faster? And yes, it does. Dr. Miller let us know about the anatomy of the rotator cuff, not cup, the cuff. And it involves four muscles: the supraspinatus, the infraspinatus, the teres, and the subscapularis. And really what it does is it doesn't help you to lift your arm up over your head. It helps to keep the shoulder centered in the joint so it doesn't slide around or translate around, so that the deltoid muscle can then help you to function with your arm over your head. And it comes together or coalesces together on the top of the humerus like a cuff, hence the name rotator cuff. And this is a view of a shoulder at the time of surgery, the humeral head and the tendons coalescing together. Innervation, we always care about the nerves, and sometimes neurologic injuries can mimic rotator cuff tears. So remembering that the suprascapular nerve goes to the supra and infraspinatus, whereas the axillary nerve takes care of the subscapularis, and the subscapularis, the teres, and the subscapularis has its own distinct innervation. And when you think about a tendon, the rotator cuff is no different than any other tendons. These are primarily water and then a breakdown of collagen, proteoglycans, and other types of cells. And functionally, as I suggested, it's not necessarily lifting the arm up over the head. It's compressing the head centrally into the socket so that the rest of the periscapular shoulder muscles can help. And if you think about that, that really makes sense why physical therapy can help people with injured rotator cuffs, because you're trying to re-educate the muscles that surround the cuff to help them function. As you examine patients with rotator cuff injuries, I think the first thing you want to do is observe. Every time you meet someone, you look, you try to assess something. One of my old professors would really lean into me if I examined a patient's rotator cuff or shoulder without really looking at all the muscles and how the scapula moves and the kinetics of the shoulder. I'd be missing the boat, or perhaps I shouldn't have the privilege of being allowed to examine those shoulders. So I want to look at presence of atrophy in the supra and the infraspinatus fossa, and I want to look at forward elevation, and I want to look at how the shoulder moves. Dr. Neer, who Dr. Miller trained with and alluded to earlier, and Dr. Hawkins, who is part of the Stebbins Hawkins Foundation that Dr. Green trained with, were early pioneers in describing how the shoulder does impinge and bringing the arm into a dysfunctional position where the greater tuberosity is going to squeeze between the bursa and the acromial process and cause pain. And the near impingement test is when the arm is lifted up overhead, and as you get to the terminal components of forward flexion, it begins to be painful. In contrast, Dr. Hawkins described the arm as getting brought across. When someone comes into my office and I examine them, my thought or my hope is that I can figure out what's wrong with them probably 85–90% of the time just by listening. And if I'm a careful listener, I'll really know what's going on, and I'll use my physical examination. And my physical examination should really hone in what I want. The secondary tests, the X-rays and/or the MRI scans that may follow, are only there to confirm what I'm already thinking. I don't order things to see what's going on. So if you keep that tenet in mind and keep your physical examination skills very high, you can really hone in on what to fix, particularly in revision cases or cases that are not doing as well as you would expect them to do. So isolating the supraspinatus with the thumb up or thumb down, the empty or open can, helps you to isolate that muscle. External rotation, the position that you examine the arm in external rotation, can really be very useful in looking at how the infraspinatus and the supraspinatus work. If you isolate the arm out to about 30 or 45 degrees of external rotation, you're isolating the infraspinatus. So now I can tell you when the supra is involved, when the infraspinatus is involved. I can also look at when the subscapularis is involved. And there's a few different tests, which include the lift off, which is lifting your arm off of your back, as you see in the young woman. The belly press, when the patient tries to take their hand and press it against their belly, in the absence of a functioning rotator cuff, the arm stays at the side. It can't go anywhere. The latissimus actually will pull it back. But in the setting of a functional rotator cuff, you can keep it out at this 90-degree test. There's also the bear hug test, more recently described by Dr. Burkhart. And it's not just one test. You can't just have one of these in your back pocket and expect to pick up all the different pathology. You need to have them all. You need to test people dynamically as well as statically to really get an understanding of what's happening. So once I've done that, once I've thought to myself, okay, I think I know what's going on, I want to think about the red herrings, the things that are on the outside. Is this coming from your neck? Is this a cervical spondylosis? Is this a disc herniation where someone's going to have terrible medial border of scapula pain, and I scratch my head and say something's not typical here? Brachial neuritis, if it doesn't start at the disc and it's not at the end, at the terminal portion of the tendon, you can find it in between. Sometimes the cords, the electrical cords can go wrong. And we see neuritis, and we actually see stretch injuries. We had a football player who came in the other day who couldn't lift his arm up after stretching his brachial plexus. The suprascapular nerve, as I suggested earlier, innervates both the supra and the infraspinatus, and this can actually become affected in different spots. And just like we all understand and think about carpal tunnel syndrome, this is the carpal tunnel syndrome of the shoulder, but a lot easier to miss. And the syrinx can be an insidious but very debilitating cause of shoulder pain and dysfunction. I do routinely get x-rays. I want to see x-rays so that I can look at the integrity and the quality of the bone. I don't want to miss a bone cyst. I don't want to miss a tumor in the bone that can be picked up by an x-ray. So holding off on that study is very important. I do look at the acromion, and we could debate for hours on whether the arch or the hook or the spur in the acromion is part of the major issue, but nonetheless, I think calcified tissue or excrescences that hang below the bone can be very, very useful. I do, when indicated, when my clinical suspicion suggests it, I get an MRI scan. Not every patient needs to go through a course of failed therapy and failed time before they get an MRI scan, but in the same token, not every patient needs an MRI scan. There's some appropriate balance, and I think that's what we need to help figure out. So when someone comes in saying, well, I think I need an MRI scan, you have to mitigate, making them feel happy and rewarded that you're doing and you're taking care of them in the appropriate way, but also being somewhat responsible, particularly in this setting of healthcare economics. The rotator cuff, again, we talked about the muscles and the tendons, and indeed, when it's functional and does a good job, you can throw the baseball, 96, 98 miles an hour, 105 times in a given game. But when it tears, it is painful and dysfunctional for not only that throwing athlete, but for myself and yourself, and for our parents and grandparents who can't sleep at night, who can't roll over on that arm, who can't reach back in the car, and don't have the function that they want. So with the failure of the appropriate modalities, attempting physical therapy, aquatic therapy is useful in retraining some of these muscles. We've made progress, and we do surgery. And Dr. Miller showed you that first patient that he had done a reverse shoulder on, who had a few surgeries. And you look at this incision that came all the way across the arm, and one of my old mentors really believed in this very large, very invasive incision and got reasonable results with it. As progress went on, this moved over to the mini open rotator cuff repair, and this is still practiced by at least 40 or 50% of the country, and for larger tears, a substantially higher number. What we do here relatively exclusively is arthroscopic rotator cuff repair. We've got a significant experience with probably over 1,000 repairs done, and find that we are able to accomplish arthroscopically the same operation that can be done with this larger incision. And I gave a talk the other day, and someone suggested, well, gosh, I wouldn't do an arthroscopic rotator cuff repair. I've seen too many go wrong. And I go in and look in there and they haven't done the job. And that's absolutely right. If you can't emulate or recapitulate the job that you do with open surgery, you shouldn't do it arthroscopically. But indeed, we can, trained properly with enough experience, you can do that exact same operation. So the surgery, sorry for a little blood and gore, but it's arthroscopy, there's not too much blood. The bursa, the bursa is inflamed, and you look at these cobwebs and you say, gosh, it doesn't look right or normal. Here's another person who's been injected a few times in the bursa, and it actually is gloms of tissue sitting on top of that rotator cuff. And you can imagine how that would be pathologic and painful. And it actually carries within it high levels of pain mediators. Substance P can be higher in that inflamed atypical bursa than it would be in a normal shoulder. Surgery, we do take off the bone spur. Here you can see half of the bone spur removed, and then I'll subsequently smooth out and create more room and functionally raise the roof so that there's a greater clearance for the shoulder to function. The pitfall, or one of the concerns, or one of the things that we've read about, is the initial experience in about 2002, 2003, was that there are a persistently higher rate of rotator cuff tears. So we've tried to come up with methodologies and ways to make this better, and I believe we have. So here you're looking inside someone's shoulder. You can see the bone of the greater tuberosity, and that's the rotator cuff torn away. It should be attached. You shouldn't be able to drive your car through that area over here. So what we do is we insert these devices. We call them suture anchors. The anchors are kind of like concrete anchors or rivets. They have stitches attached to them. And now I take the stitches and I pass them through that tissue. And by passing them through the tissue, and this is a device, it's like a needle on a long stick, and inside of it, it has has a metal loop or wire that I can shuttle, so I can pass stitches through the tendon this way. This is how you build the ship inside the bottle. So I pass these through, and I pass a series of stitches through, and whether it's 2, 4, 6, 8, or 10 stitches, it doesn't really matter. You do whatever it takes, but you can do this in a very accurate and reproducible way, and the visualization is tremendous. And I grab it through, then I'll pass it again. You can see here I am deciding exactly where I want to be with this device, and I pass it through. I send the guide wire out. I grab the guide wire with my suture grasp or crab claw. We have a lot of funny names for instruments in there. And I have a blue and a white stitch, not because they're different, just so that I can have some color coordination and not get myself into tangles. I'll then, after I finish passing these through, I'll then start to tie these down. And these are the knots we learn from the sailors. And you can see this is a knot pusher device and a small, tiny little knot that I'm going to tie. And I'm pushing that rotator cuff back down into where it belongs. Once I finish tying it, I'm going to link it out. I'm going to link it to another set of stitches. And again, my goal here is to recapitulate the open technique. I use a small awl and create a hole. What we found in a study that we've just finished that will be ready for national level presentations is that if we fix the rotator cuffs, the large tears with this technique, we're getting substantially better rates than what's published elsewhere. So they're healing in over 80% of the situations, whereas the experience from other centers in this country are somewhere between 30 and 50%. This technique has not yet been published upon, although we've been doing it now for about 4 years. And it was developed in Los Angeles by the doctors at the Curlin Job Clinic who trained me. Here you can see I'm finalizing the repair, putting this last anchor or rivet in, and this rivet is going to secure these 2 stitches into place that you can see over here. And by securing them in place, I now have a construct where, as I move this rotator cuff around, you can't see where that tear really was. And you're looking at this at 15 or 20 times the magnification, and you can't see any small amounts of motion. So it really is a very secure anatomic reconstruction of the rotator cuff. The last thing that we're going to talk about is what's exciting, what's new, looking at some different growth factors. Here is, and this is, as Jeff Heffler alluded to, we are using some of these platelet-type plasmas. Here is a rotator cuff, and what I'm doing here is taking a collagen matrix sponge, and relatively inert sponge. The sponge has been soaked in growth factors. After we've soaked it in autologous growth factors, after we soak it in, I do the same type of bridge repair, and I sew in this growth factor patch. Do I know for sure that this is going to make a difference and make you heal? No, not for sure. I think that we've got to study that and follow it out. But certainly enhancing our own biology is the next frontier in arthroscopic shoulder surgery, and that's what we're working hard to do both here and at different centers across the country.